Hi everyone, thank you so much for listening in on this presentation. My name is Hediye Kendanru Shakib and I'm a fourth year pharmacy student at Texas Tech School of Pharmacy. Today I will be talking about congenital hyperinsulinism. By the end of this presentation, you should be able to describe the pathophysiology of congenital hyperinsulinism, be able to summarize the symptoms and diagnosis criteria for congenital hyperinsulinism, summarize the current treatment guidelines for its treatment, and lastly, be able to briefly describe the new emerging therapy in congenital hyperinsulinism. So I will start with what is congenital hyperinsulinism, or CHI for short. It's essentially a condition that results in persistent hypoglycemia in infants and children due to dysregulated insulin secretion. It's currently the leading cause of persistent hypoglycemia in neonates, and its incidence is very rare. It approximately happens in 1 in 50,000 live births. And hyperinsulinism causes not only hypoglycemia, but it can also suppress lipolysis and reduce ketones that act as an alternative fuel to maintain brain neuronal function. So hypoglycemia that is caused by CHI is detrimental to the brain, and it can have adverse neurodevelopmental effects in these babies. There are different types of hyperinsulinism, or HI for short. The first one is perinatal stress-induced HI. It's essentially a transient form of HI that happens in neonates, which is caused by perinatal stressors, and those could be placental insufficiency, birth asphyxia, maternal diabetes, or even certain medications that the mom was on during pregnancy or even prematurity. The second type is monogenic form of hyperinsulinism, which is essentially mutations that can happen in genes that are associated with insulin secretion and beta cell development. And lastly, it's syndromic hyperinsulinism, which is several overgrowth syndromes that are associated with HI. And the most common one is Beck-Whitman syndrome, or BWS for short. It can cause hemihypertrophy in infants and children. And the second most common one is Kabuki syndrome, which is associated with facial dysmorphism. There are also different histological subtypes, and the first one is a diffuse disease. In diffuse disease, all the islet cells are similarly affected, as you can see in the picture on the right with those brown spots. That's all throughout the pancreas, and this is often inherited as either an autosomal dominant or recessive pattern. And the second type, which is focal, that only affects a small portion of the pancreatic beta cell, and this one is usually sporadic in inheritance. Now let's talk about how it can present clinically. Essentially, when blood glucose levels are less than 50, which usually happens preprandially, but postprandial hypoglycemia can also happen on rare occasion. These infants could also be either small or large for their gestational age, and it happens with hypoglycemic symptoms, so poor feeding, jitteriness, hypothermia, lethargy, seizures, and apnea. And as most of you are probably already thinking about this, symptoms of the CHI could be very, very nonspecific in neonates. As far as the diagnosis goes, if an infant is having a hypoglycemic events, we should run lab tests at that time of the hypoglycemic episode just to see what their numbers look like. But generally speaking, if all of the criteria that I will talk about in a second are present, then hyperinsulinemic hypoglycemia could be diagnosed. So if glucose infusion requirements are greater than what we usually provide to infants on a normal basis, of course, low plasma glucose, the presence of any detectable insulin or C-peptide confirms the diagnosis of HI, but I want to emphasize that undetectable insulin or C-peptide do not exclude the diagnosis. These patients would also have low insulin-like growth factor binding protein, would have inappropriate low plasma free fatty acid and ketone bodies, if ketonuria is absent, or if they have an exaggerated response to glucagon. Now, how do we treat this acutely? Of course, if it's a single hypoglycemic event, we would give them a bolus of 2 ml per kilo of dextrose 10%. If they have persistent hypoglycemia, then we would start them on continuous glucose infusion at 6 to 8 milligram per kilo per minute. That is also titrated to achieve and maintain normal glycemia. Now, keep in mind that infants with CHI have been shown to require infusion rates as high as 25 milligram per kilo per minute. So if we are worried about fluid overload, then we can also start these infants on concurrent continuous IV infusion of glucagon. Now, if there is no IV access available, then we can give them glucagon 0.5 to 1 milligram subcutaneously or IM. Now, this is all in addition to feeding the baby, of course, but one of the rare side effects of glucagon therapy is necrolytic migratory erythema, as it's shown in the picture on the right. It's typically a rash that spreads with a red irregular border, but it starts to disappear within a day or two after glucagon therapy is stopped. After the infant has been diagnosed with CHI, we would start him on a diazoxide trial, which means we'll start diazoxide at 5 milligram per kilo per day, given orally in 3 divided doses. In some severe cases, it can be started at 10 milli per kilo per day, and it can go as high as 15 to 20 milligram per kilo a day. Now, because diazoxide can cause fluid retention, chlorothiazide is started with diazoxide concurrently at 5 to 15 milligram per kilo per day. That's given also orally in 2 divided doses. Chlorothiazide also has synergistic effect to prevent insulin secretion along with diazoxide. Diazoxide also has another side effect, which is excess body hair that happens mostly at higher doses. Now, if plasma glucose is maintained at 70 or higher after the infant has been on diazoxide for a few days and monitored, then it would be safe to say that diazoxide is working and that the infant is diazoxide responsive. And in that case, the infant can be discharged safely home. Now, if normal glycemia is not achieved after receiving the maximum dose of diazoxide for at least 5 consecutive days, then it would be considered diazoxide unresponsive. In the case that the patient is not responding to diazoxide therapy, we have to do a prompt genetic testing to find out which genes are actually being affected by CHI. And the second-line treatment that is usually started in these patients is octreotide at 5 microgram per kilo a day, given subcutaneously in 3 to 4 divided doses. And it can go as high as 35 microgram per kilo per day. Now let's switch gears and talk about a study that was published in 2022 about a new medication for the treatment of CHI. This new medication is called Exendin 9-39, which is a competitive antagonist of glucagon-like peptide 1 or GLP-1 at the receptor, and what it does is inhibits the insulin secretion. So the study objective was to assess whether this medication will increase fasting and postprandial plasma glucose and decrease the incidence of hypoglycemia in children with hyperinsulinism. The study population included 16 children who were all diagnosed with CHI, who aged 10 months to 15 years, and this was an open-label 4-period crossover study. In periods 1 and 2, Exendin was given at 3 different strengths, 0.28, 0.44, and 0.6 mg per kilo versus vehicle, and the vehicle was just an NS infusion. In periods 3 and 4, a subset of 8 subjects received Exendin 0.6 milligram per kilo versus vehicle during a mixed meal tolerance test or MMTT and an oral protein tolerance test or OPTT. So the MMTT was after the subjects ate a solid breakfast meal that consisted of 55% carbs, 15% protein, and 30% fat. And the oral protein tolerance test was at 3 hours after the breakfast meals when they drank a protein shake. What they found was that in comparison with the vehicle, treatment with Exendin increased the area under the curve or AUC of fasting glucose. It decreased the fasting AUC of insulin, and it also resulted in significant reduction in likelihood of hypoglycemia, while the AUC of insulin was unchanged during the MMTT, and it was almost 2-fold higher during the OPTT. What they concluded is that these results support a therapeutic potential of Exendin 9-39 to prevent fasting and protein-induced hypoglycemia in children with HI, which I definitely agree with. And this concludes my presentation. Thank you so much for listening in, and please reach out if you have any comments or questions. Thank you so much.